Hello and welcome. Today we are going to talk to you about the WHO Labor Care Guide. This video will describe how you can use the World Health Organization Labor Care Guide for your patients. The Labor Care Guide and user manual can be downloaded free from the World Health Organization website, and the link has been provided in the description below. The World Health Organization Labor Care Guide is an essential birthing record tool. It can be used at all levels of healthcare facilities with all levels of healthcare providers. It has a built-in alert process for involving a senior doctor or a nurse provider. The guide and its accompanying user manual has been designed to allow proper use of the partogram. The information recorded in this sheet can also be used to conduct audits on the process and the outcome of labor in a center or a hospital. And it can also be used for research. There is a list of acronyms and abbreviations which has been used in this guide, and these abbreviations are present in the Labor Care Manual. They are standardized and used across the board for better understanding by different providers who are looking after the patient. WHO recommends that we should use evidence-based practice for the care of women having babies. The Labor Care Guide Manual is developed for guidance to all healthcare providers, managers of facilities, and implementers and managers of programs which are looking after maternal and child health, as well as NGOs and professional societies involved in the planning and the management of maternal and child health services. To summarize the key points on starting the Labor Care Guide, all women in labor should be cared for according to the recommendations of the guide. If a woman is high risk, then additional monitoring will be required. And this is a very important point to remember. The guide is to be initiated when the woman has entered the active phase of the first stage of labor, which is 5 centimeters or more dilatation. It can be used for all levels of care in health facilities. The chief advantages of the guide are that it promotes improved respectful care during labor and childbirth, improved labor support and care leading to improved outcomes, more accurate assessment of the fetus, more accurate assessment of the progress of labor, better assessment of the mother, timelier evidence-based interventions, documentation of care during the second stage, and greater accountability. The Labor Care Guide has background information about the patient at the top of the partogram. At the bottom of the partogram, there are a list of abbreviations for ready reference. The partogram is arranged in 7 sections. Section 1 is for documenting the woman's name and labor admission characteristics that are important for labor management, parity, mode of labor onset, date of active labor diagnosis, date of and time of rupture of membranes, and risk factors. Section 2.7 contains a list of labor observations. The healthcare providers should record observations for all the sections soon after the woman is admitted to the labor ward. The remainder of the guide is then completed following subsequent assessments through labor. For all observations, there is a horizontal time axis and for all the alert observations, there is a vertical axis. Now this axis is not present in section 6 and section 7, but up till section 5 there's an alert for every recording that is being done in the guide. The cervical dilatation assessment will end at the first stage of labor. So here there is a gap here. Question: how do we complete the guide? Do we use numbers or abbreviations or symbols? When a measurement is numerical, the actual number should be recorded. When documenting observations, for example, support present, abbreviations are used. These are standardized and the same always, so that every member of the healthcare team can understand them. This slide is showing the first row of section 1, which is the time. The actual time is written in the top row, while the second row identifies the number of hours that have gone by since the partogram was started. Each column represents 1 hour. As described in this example, if the first assessment is conducted at 6:30 a.m. and the second one 1 hour later and 2 hours later, the actual time can be recorded either as 6:30, or it can, even if it is in the morning time, or 06:30 if you want to record in the 24-hour clock. So if this was 6:30 in the evening or 6:30 p.m., then it would be recorded as 18:30 hours. Now in this example, we see that the recording will stop here at 12:30 and is then transferred into the second stage of labor. So the second stage of labor is recorded on the extreme right-hand side of this section. Supposing the labor extends beyond 12 hours, then a second labor care guide form will be commenced. But at this point, there should be a review by a senior provider to confirm that the patient management is being conducted along the proper lines which are recommended according to evidence-based medical guidance. So this section captures the woman's name and some basic information. The onset of labor and the onset of active labor is written down, as well as the time for the membranes ruptured. High risk factors are written on the partogram so that every person who is looking at the partogram becomes aware of the background information for this patient. The section 1 records the full name, parity, onset of labor, which may be either spontaneous, and you write down an S for spontaneous, or write down the entire word, and induced. So induced is in any situation where some method has been used to stimulate the process of labor, which can be oxytocin, prostaglandins, or it can even be a physical method like applying a balloon to the cervix or any other drug. In this section, we also include the active labor diagnosis, the date when first stage of labor was diagnosed. So this date will be written down as date, month, year, so that we have a complete record for the sake of audit. The date and the time when the membranes were ruptured must be documented, and if supposing the patient does not know about the date or the time when this occurred, then you have to write down U, which means unknown. And important risk factors are written down to make sure the providers are reminded of the patient's special needs. So this is an example of a completed section 1. As you can see, the parity, the labor onset, the date and for the active stage of labor diagnosis, the date and the time for the ruptured membrane, and the risk factors are mentioned up front as stillbirth and anemia. In section 2, we document the support for the patient as labor, during labor. In section 2, we include the presence of supportive care. If the patient declines the presence of a companion, then we write the letter D. But if she has no companion, it is an N, which is an alert. If the patient is not having oral fluids, again, this is an alert. If she is not having pain relief, this is an alert. If she's lying down in bed supine, again, an alert. Patient should be assuming a posture which is comfortable for her and preferably should be more mobilized. In this slide, we have further guidance about the completion of section 2 of the guide. So if the patient has a companion of her choice present and who is providing support, this is the optimal situation which enhances and facilitates labor. If there is none, this is an alert, and the provider should offer to find a companion of the woman's choice. Pain relief is also documented, and it is advisable that the patient has pain relief. If the response to this row is no, this is an alert, and the provider should offer some method of pain relief, whether it is an epidural or it is opioids or relaxation breathing, mindfulness, music, or manual techniques based on the patient's preference. There is more explanation about the recording and documentation of section 2. The woman should be offered oral fluids, and if she is not taking oral fluids, this is an alert. If she is lying supine in bed, it is an alert. The provider should encourage and support the position chosen by the patient. Here we see a completed section 2. As you can see, alert abbreviations are encircled by a red pen. No companion, no pain relief. Oral fluids are being taken and the patient is mobile. In the second observation, which is done 1 hour later, we find that she has now got a supportive companion. Pain relief is present. Oral fluids are being taken. But now the patient is assumed a supine position and should be encouraged to move. In section 3, we facilitate decision making while monitoring the well-being of the baby. And the well-being of the baby is monitored by regular observation of baseline heart rate, decelerations in the heart rate of the baby, amniotic fluid color, fetal position in the pelvis, molding of the fetal head, and development of caput succedaneum, which is a diffuse swelling of the scalp. This slide shows the section 3 of the recommended partogram. And as mentioned before, all the different elements are mentioned here with the alert signs. So we listen to the fetal heart rate for a minimum of 1 minute. This is if you're not doing continuous fetal heart rate monitoring. So the heart rate can be heard either by a Pinard or preferably by a Doppler. Should auscultate during a uterine contraction and continue for at least 30 seconds after the contraction. At the same time, also assess the woman's pulse to differentiate between the heart rate of the baby and that of the mother. If the fetal heart is less than 110 or more than 160, this is an alert. And a senior healthcare provider should be contacted. Section 3 here documents fetal heart decelerations. So if we listen to the fetal heart rate after the uterine contraction, then we will know whether there is no deceleration, early deceleration, late deceleration, or variable deceleration. Late deceleration is an alert and indicates that you should put the patient on her side. If she's having too many uterine contractions, stop the oxytocin and contact senior healthcare provider. When the membranes are ruptured, amniotic fluid will be seen at the vulva and on the sanitary towel which is being applied to the vulva. If this is clear, this is normal. But if very heavy and significant meconium is present, this is an alert sign indicating that a senior provider should be contacted. More guidance for completing section 3 includes gentle examination of the patient using aseptic technique to assess the fetal position. If the baby has occipital transverse position or occipital posterior position, then contact the senior care provider to make sure they know that this patient might require some assistance later on at the time of birth. When performing vaginal examination, we also assess other clinical parameters such as the presence of caput succedaneum. And if a very large caput succedaneum is present, it is an alert sign. While palpating the fetal head, we also look for molding. And if the molding is very severe, the sutures are overlapped and they are not reducible on the fetal head, this is an indication of an alert and a senior healthcare provider should be contacted. Here we see the second section of the partogram, and this has been filled by a provider, and the only alert sign that we see is the posterior position of the fetus in the pelvis. So this was noted at the first examination, which was done at 6 o'clock, and this alert sign should be informed to the senior provider because this may predict either a prolonged labor or even an obstructed labor. We will move on to the section 4, which is the care of the woman. In section 4, the mother's pulse, systolic blood pressure, diastolic blood pressure, temperature, and urine is checked regularly. All the observations are noted in a numerical form except for the assessment of the urine. Guidance for completing section 4 of the labor care guide includes that pulse should be counted for at least 1 full minute. And if the pulse is less than 60 or more than 120, then this is an alert sign and a senior care provider should be alerted. The systolic and diastolic blood pressure is noted in actual measurement and the alert levels are also recorded. Blood pressure is measured with any accurate recording device available. If the systolic blood pressure is less than 80 or more than 120, a senior care provider should be contacted. Similarly, if the diastolic blood pressure is greater than, equal to, or greater than 90, a senior care provider should be contacted and guidelines should be followed. In this slide, we show the documentation of the body temperature. The measurement of body temperature is done by a thermometer which is placed in the axilla, and a low temperature or a high temperature is an alert sign indicating either hemorrhage, cardiac disease, or a high temperature may indicate infection. Urine dipstick is used in all settings to check the maternal urine sample. The findings are indicating A for acetone and P for protein. And the quantity of protein or the quantity of acetone is then documented as 1 plus, 2 or 3 plus. The alert findings must be interpreted according to the clinical situation and involve a senior clinician or a senior care provider. This shows how the guide could be completed with all this information. We can see the section on supportive care, care of baby, and care of woman. And there are some red circles. These red circles mean that there is an alert sign. So the recordings are done only when the measurements are made. So the frequency of the observations will differ for each section. But usually vaginal examinations will be done either 2 hourly in high risk cases or 4 hourly in routine cases. Section 5 documents the progress of labor, and this section aims to encourage the systematic practice of the intermittent monitoring of labor progression and parameters. The frequency of contraction, duration of contraction, cervical dilatation, and descent of fetal or the baby's head is documented. This section shows the partogram for recording of progress in labor. Section 5 also monitors the uterine contractions over a 10-minute period. If the contractions are less than 2 or more than 5, the provider is alerted to take action. The observations are made every 30 minutes during the first stage of labor and every 15 minutes in the second stage of labor. Section 5 also checks the duration of the contraction. This means for how long does each contraction last. If the duration of contraction is only 20 seconds or less, this is an alert. And if it is more than 60 seconds, this is also an alert, which means hyperstimulation. Section 5 measures the changes in the cervix. When the vaginal examination is performed, all the parameters are assessed. During vaginal examination, the provider should be gentle, should always obtain consent before examining, should ensure privacy, and use aseptic technique. The slide is very busy, and the column on the third aspect, that is checking threshold, cannot be easily read. It will be shown in the next slide. This is the detail for the third column seen in the previous slide. It shows a magnified view of the content in the column for check threshold, which means alert. The alert has different way of assessment for the first and the second stage of labor. In the first stage, there is no change in the dilatation, then consult the chart. Similarly, if in the second stage, labor birth is not completed in 3 hours in primigravida, or if birth is not completed in 2 hours in multigravida, this is an alert and you should inform senior obstetrician. The slide is showing how to measure and interpret the descent of the fetal part. In this slide, we see the recording of the cervical dilatation and the birth of the baby. At the extreme left is the vertical scale of centimeters. Next to this is the scale of hours. The provider can plot the dilatation in centimeters and the time it took for dilatation. If the cervix is 8 centimeters dilated, then within 2.5 hours, it should change actively towards full dilatation, as it happened in the patient for whom the documentation has been done on this slide. The red circle identifies that in the second stage of labor, the cervix is now fully dilated. However, the patient is in the supine position. But the patient is probably comfortable in this position and she's pushing, and the P indicates that pushing is taking place actively. Here we can identify the descent of the presenting part of the fetus from -4 to 0 station in 4 hours. As you can see, the recording has stopped here because the patient is now fully dilated. So the full dilatation has been now shifted to the second stage of labor. In section 6, we have to complete the list of medications which are being used during labor. This includes oxytocin, other medications, and intravenous fluids. As you can see, there is no alert in this section, and the only parameters that we have here are assessment and recording. We next move to the section on assessment and plan for decision making. The overall assessment for a column is written down and in the plan we record the details of the plan. This may include continuous monitoring, prescription for diagnostic tests, augmentation of labor with oxytocin, rupture of membranes using forceps for delivery of the baby. Any decision which is taken after recording an alert should be in consultation with the senior provider. In addition, before implementing plan, we have to counsel the patient and always obtain consent from the patient. So here we have a section which has been completed for a patient, and the red circles again are indicating alert findings, whereas as you can see that in the medicine and in the IV fluids, there are no alert sections. This is showing recording of the shared decision making. By shared decision making, we mean that the patient is involved in the decision making and consents to the decision making. The provider has documented need for pain relief and a normal progress in assessment, and in plan has documented continuous monitoring and giving support to the patient. With this, we come to the end of the recommended WHO Labour Care Guide, and now we move on to summarization of the similarities and the differences between the WHO recommended partogram and the labor care guide. The similarities include documentation of the name and parity, plotting the progress of labor, regular documentation of well-being of baby and the mother, and documentation of oxytocin, drugs, and intravenous fluids. If we look specifically at the different items, we see that gravidity is not being recorded anymore, and date and time of admission is not being recorded. However, we are recording supportive care, risk factors, type of onset of labor, time of ruptured membranes, and the date when the first stage of labor was diagnosed. Here we see that the fetal heart rate was first plotted on the graph as a graph, but now an actual number is being recorded. And we are now also recording decelerations, fetal position, and fetal caput is also being recorded, as well as molding. Pulse and the blood pressure is written down as an actual number. Urine volume is not being recorded. The frequency and the duration of the uterine contractions is recorded rather than the strength of the contractions, which is highly subjective. More important differences are the starting point of active phase of labor, which is now 5 centimeters. In the previous partogram, the alert and the action lines were present. In the WHO labor care guide, the reference threshold values are written as such and decisions made according to the alerts. The second stage is now mentioned without the cervical dilatation. Time when pushing starts is documented. It requires circling, preferably in red pen, to identify if the criteria is an alert. Assessment of findings, plan of care, and provider's initials are added to the WHO labor care guide. In conclusion, we can say that the introduction of the WHO labor care guide will facilitate effective implementation of the 2018 recommendations of the World Health Organization. It will provide a positive childbirth experience for the patient and the fetus. It will promote a shift towards improving the experience of childbirth, and it will improve the quality of care during labor and childbirth and maternal and newborn outcomes for all pregnant women. The guide provides an opportunity to audit the labor process and to improve it. It also provides an opportunity to conduct research with the accurate recording of timelines. With this, we come to the end of this presentation. Thank you and goodbye.